Today, we'll study heart failure, which is a very important topic. Questions are often asked about it. As the name suggests, heart failure means the heart has failed to do its job. And what is the heart's job? Well, in the heart, like this one here, this side is the left side and this side is the right side. This is an atrium, this is also an atrium, this is the left ventricle, and this is the right ventricle. So blood from the entire body first enters this right atrium, then it goes into the ventricle, and from the ventricle, it travels through the pulmonary artery. It goes to the lungs on both sides, and then it returns through the pulmonary veins. 2 veins come from one lung, and similarly, 2 veins come from the other lung. And after that, these pulmonary veins bring this blood and dump it into the left atrium. From the left atrium, the blood enters the left ventricle. Once the blood is in the left ventricle, when the heart contracts, it has to push this blood throughout the entire body. That's the heart's job. Now, what happens here is that of all the blood that has arrived and collected here from above, the heart must push out 55 to 75% of that blood through contraction. This ensures that all the body's vital organs, like the kidneys, brain, and lungs, receive proper perfusion, and the supply of oxygen and blood continues. That's the heart's job. But in a heart failure condition, the heart can't do this job. That is, the heart can't push effectively. It can't pump out the amount it's supposed to. Suppose 100 milliliters of blood was supposed to come here, and that 100 milliliters collected in the left ventricle. When the contraction or beat occurred, it pumped out less than 45% of the blood. This means it's now in a state of heart failure. So what happens in heart failure is that the heart is still working, but it's doing less work than it should. This means the heart is weak. In heart failure, the heart hasn't completely stopped working. It's working, but it's doing less. That's what we call heart failure. And in this, if it doesn't push the blood forward, it means the forward movement where the blood came in like this and was supposed to go forward. Now the aorta is actually shaped like this in reality, but to keep the image simple, I've shown the aorta a bit lower down. So the blood that was supposed to be pushed forward from the left ventricle has decreased. That is, the forward movement of blood has slowed down. Now, if the forward movement decreases, then the blood will start moving backward. This means in a heart failure condition, what will happen? In a heart failure condition, the heart is weak. Because it's weak, the forward movement in the heart, the movement of blood has decreased. It's gone down, while the backward movement has increased. And what happens in this is that normally when the heart contracts once, when there's one beat, then in this left ventricle, the amount of blood that was in there, the amount that gets pushed out, we call that the stroke volume, meaning the stroke that occurred once. The amount that gets pushed out by that is what we call the stroke volume. And the amount that comes out in 1 minute, meaning how many strokes in a minute, how many times it beat, the total blood that comes out is called cardiac output, which is the stroke volume multiplied by the heart rate. That's what it is. Normally, what happens is that the stroke volume decreases in this. A lower stroke volume means, suppose the amount of blood that comes out here from the amount of blood that entered here. Normally, the stroke volume, the normal stroke volume is around 75 milliliters. So this 75 milliliters amount, it decreases. If this decreases, it means the cardiac output will also decrease. This is what happens in heart failure, meaning the heart is working, but it's underperforming. Another thing is why this happens. So that was heart failure. Let's look at its causes. For example, for the heart to contract, the heart cells need energy, meaning the myocardium. The myocardium, there are 3 layers of the heart. So in these 3 layers, like suppose these are the 3 layers of the heart, the outermost one is the epicardium, the middle one is the myocardium, and this is the endocardium. So this middle myocardium, its energy, these are the muscles in it. Only when there's a contraction in it can a beat occur. Now suppose there's a condition of myocardial infarction, meaning an MI condition. In that condition, if there's an MI condition means for a long time, the oxygen supply to the heart wall was cut off, causing the heart wall to get damaged. Now, suppose this ventricle wall, if this much part of it gets damaged due to lack of oxygen, If oxygen wasn't received and it got damaged, meaning it infarcted, then it means this condition is an MI. So due to myocardial infarction here, now the amount of contraction that should have happened in this wall won't happen. It won't happen, meaning the heart won't be able to push as powerfully as it should. So the first cause of heart failure is MI. So one reason for this is MI, which is myocardial infarction. Because of that, weakness is developed here. Due to this weakness, it cannot contract. Another reason could be that to push blood from this left ventricle, the pressure here must be higher than the pressure in the aorta. So pressure here should be high, but pressure here should be low. If the pressure in this aorta is low, then when the heart contracts, it can effectively push out more cardiac output. This means it can push out more blood. But suppose the pressure here is the same as the pressure in here, then when the heart contracts, it won't be able to push out much blood. This means if, let's say, the pressure here is elevated, if the BP is high here, because of high BP, because of high blood pressure, when the heart contracts, it won't be able to push the blood out effectively. This means hypertension is also another cause of it. So due to hypertension, the heart is unable to push the blood out properly. And if the heart cannot push effectively, that's exactly what we call heart failure. So its second reason is hypertension. Or maybe these blood vessels are constricted. Due to constriction, the pressure here will increase. If they are dilated, the heart can easily push the blood out. If they aren't dilated but are constricted, meaning if all the blood vessels in the body are constricted, the heart will have to apply more pressure to pump, so the cardiac output will automatically decrease. So this means it will now fall under hypertension. After this, the next cause was that when the heart contracts, during that time, these valves should be closed. Now, once all the blood has collected here and they contract, these valves, meaning the tricuspid and mitral valves, both should close. If they close before the ventricle contracts, then all the blood, or rather most of it, will be pushed into these blood vessels. But if it doesn't contract properly, say there's a defect in this valve, because of that defect, when the ventricle contracts, the blood will move backward. And when this blood leaks back through this valve into the atrium, the amount of blood moving forward decreases. This means the heart can't eject as much blood as it should, and that's exactly what we call heart failure. So the next cause is valvular abnormality. Besides that, another major cause of heart failure is when the heart's rhythm is off. If the rhythm isn't proper, the heart fails to pump blood out effectively. Normally, what happens is that in the right atrium, there's an SA node that generates impulses. These impulses cause the atria to contract, and then they travel through the AV node into the ventricles, causing them to contract as well. Now, these impulses generated by the SA node are typically only able to produce between 60 to 100 beats per minute. But if other parts of the atria start contracting on their own, meaning cells in different areas of the atria begin generating their own impulses or firing, suppose this part of the atrium generates an impulse and this part over here does as well. Usually they come from the SA node, but now they're starting from all over the atrium. So look, if you had 100 beats from here, and then you add 20 more from here, 20 from here, 20 from here, 20 from here, 20 from here, and 20 from here, the heart rate could potentially, so it's possible that at least 200 to 250 beats per minute are being generated here. And in this condition, what happens is that the atria will contract very rapidly. If the atria contract rapidly, it's called atrial flutter. So this means that in the condition of atrial flutter, what will happen is that these impulses generated will then travel through the AV node to the ventricles. And when they reach the ventricles, there will also be rapid contractions in the ventricles, which we call ventricular tachycardia. Now, the faster the ventricle contracts, the less time it will have to fill up properly. Now, when blood is coming from here, it should remain dilated until all the blood from above has completely moved down here. After that, it should contract. But as blood starts coming from above, right then, many impulses are generated in the atria above, causing it to contract. This means it contracts before it's fully filled, before the ventricle is full. So when blood is pumped out from here, the volume will be lower. Because there was less blood available inside. Because while it was filling, this part should have remained dilated. It should have been in a resting state, but before that, an impulse came from above and made it contract so the ventricle couldn't fill up completely. As a result, it now has a smaller amount of blood available, and when it contracts, the cardiac output decreases, meaning the stroke volume decreases, so the cardiac output also decreases. This means the heart didn't pump out as much blood as it should have. So this is also a condition of heart failure. And the reason we saw for this is atrial flutter. Atrial flutter means when the atria start beating very rapidly like this. Instead of a normal beat, they start beating quickly. We call this atrial flutter. After that, if there's tachycardia in the ventricle will have less time to fill up. This means the ventricles will have less blood available to pump out. So the next cause of heart failure would be ventricular tachycardia. So those were its causes. Now, let's see what happens in a heart failure condition and what signs and symptoms appear in it. So now let's look at the signs and symptoms of heart failure. We've already seen that in heart failure, the blood can't be pushed out effectively, meaning there's less forward push. And because of that, the backward movement of blood increases. So instead of the blood going forward from here, it starts moving backward. This means that this blood will come into the left atrium, and after coming into the left atrium, this blood goes back. Normally what happens, look at what normally happens once. Blood comes from the whole body, then it enters the right atrium, from the right atrium to the right ventricle, and from the right ventricle to the pulmonary trunk. The pulmonary trunk divides into both sides, and after dividing, it goes into both lungs. So this was the blood flow, and from here, it comes into the pulmonary lungs, and after coming into the lungs, it comes into the pulmonary vein. This means blood is coming from this side. Normally, blood comes like this, and in this one too, blood comes like this. So now, this blood that comes from here, after being oxygenated, it should come into our left atrium. After coming into the left atrium, it should go into the left ventricle, and from the left ventricle, it should go to the whole body. But now, in the condition of heart failure, what happened is that the forward movement, meaning the forward flow, decreases. And at the same time, backward movement also increases. Look at this. Normally, blood comes like this. So there's no hypertension here, no pressure increase. It comes as it should. Now the blood will go down from here. And at the same time, it will also start moving backward towards the upper side. Now here, because if it can't go forward, because the heart couldn't push all the blood due to being weak, or maybe there's hypertension ahead, so the blood didn't go out. Now this blood will come back. It will find this path to go. From here, this blood will come back and arrive here. So this is the pulmonary artery. Now in this pulmonary artery, oxygenated blood is coming from one side, and from the other side, the blood that had collected here is coming this way due to backward movement. So this means the pressure here will now increase. The blood pressure will increase. So it means here, pulmonary hypertension will occur. Pulmonary hypertension, or what we call pulmonary congestion, will start to happen. That is, in the pulmonary area, whether it's the pulmonary vein, the lungs, or the pulmonary artery, when congestion increases, meaning the amount of blood increases, we call it pulmonary congestion. Pulmonary congestion, which affects the lungs. Sometimes the symptoms of left-sided and right-sided heart failure are asked about. So the symptoms that will occur in the left-sided heart failure we're studying now. So this means now this. There were two symptoms. We have already seen them. Whenever left-sided heart failure occurs, we saw here that pulmonary congestion, backward movement happens starting on the left side, meaning it started in the left ventricle. After that, the blood will move further back, and then in the pulmonary vein, blood was coming from one side and going to the other, which means pulmonary congestion and pulmonary hypertension have occurred. So we have two symptoms here, pulmonary hypertension and pulmonary congestion. After that, this blood will continue to move further back from here. And as it goes back, blood is coming from the pulmonary artery on one side. Sorry, here. Yes, blood is coming from the pulmonary artery on one side. Now, after this blood arrives, it will reach the lungs. And we know it will reach both lungs. The lungs contain tiny alveoli, which are sac-like structures that we call alveoli. These alveoli here. In these, what mostly happens, if I zoom in a bit to show you, this is an alveolus. Inside the lungs, there are many such alveoli, but if I show you one alveolus, what happens is that from the oxygen and all the air that has entered the lungs, the oxygen will go here into this blood capillary, meaning oxygen will come here and the carbon dioxide will be put into this alveolus. And after that, the carbon dioxide will leave the lungs and be exhaled into the environment, and the oxygen will go into the blood. This is what normally happens, and it occurs when there is no extra water collected inside these alveoli. This means gas exchange happens here, which brings oxygen into the whole body and releases carbon dioxide. But we saw that in the condition of heart failure, the blood was coming from here to be oxygenated, and as the blood arrives, there is also backward movement from behind, which caused pulmonary congestion and pulmonary hypertension. Now, as the pressure increases here, the hydrostatic pressure rises, and whenever the pressure increases, what happens in the capillaries is fluid will start to leak out from right here. This means water will come out and it'll start to collect right here. This water has now entered here. Now, once the water has entered here, the oxygen that was coming from that side, for that oxygen to go inside, to enter the alveoli, it won't find any space to cross over and move forward. And on this side, the carbon dioxide that was present in the blood, it won't be able to get out because water is already collected inside the alveoli. Because of that, gas exchange will not occur. So this means another symptom will appear here. The patient won't get oxygen, which means they'll have difficulty breathing. So we will call that, what problem does the patient have now? Dyspnea. And you must remember, dyspnea always occurs in left-sided heart failure. Because right now we are studying the symptoms or clinical manifestations of left-sided heart failure. So why did dyspnea occur? Because for gas exchange to happen, there is no space inside the alveoli. Since the alveoli are already filled with water, gas exchange didn't happen, causing dyspnea. Whenever dyspnea occurs, this dyspnea is mostly much worse for the patient at night. During the day, what happens is when a person is walking or standing, doing some activity or sitting, the extra fluid that had collected in the body, all of it, stays within the extremities because of gravity. That is, gravity has pulled that blood or that fluid downwards, due to which it collects in the legs or in the hands, in the extremities. Now, if it collects there, less of it will travel back to the heart. Less will reach, meaning the amount of blood in the heart will be lower. If the amount of blood in the heart is lower, then less will reach the lungs. And if less reaches the lungs, it means less fluid will collect in the alveoli. But as the patient lies down at night, what will happen due to lying down? Now, when he's lying down, these are his feet, these are his legs, this is his whole body, and this is his face. So now, look, because of gravity, earlier he was standing up. Now, from here, more fluid has reached the heart. More reaching the heart means there will be more blood in the heart. Now, if there's more fluid in the heart, then more fluid will also enter the lungs. If more fluid enters the lungs, it means that inside these alveoli, more water will collect, and as more water collects, gas exchange will stop. The patient will have difficulty breathing and will immediately sit up from lying down. And this happens suddenly because as soon as the patient lies down, suddenly, all the fluid from the body shifts towards the heart because when the patient was standing, gravity was pulling the fluid down, meaning the fluid was lower. And as they lie down, it reaches the heart. From the heart, it reaches the lungs. And in the lungs, it reaches the alveoli. Once in the alveoli, gas exchange stops, causing breathing difficulty. This all happens suddenly. So for sudden, we use a specific term. The word we use is paroxysmal. Paroxysmal means sudden because this incident happened quite suddenly without warning. And it occurs at night. So the word for night is nocturnal, and then dyspnea. So the patient has paroxysmal nocturnal dyspnea. Nocturnal means at night, and dyspnea means difficulty breathing. Besides that, what happens is when air comes in here, this air, previously when air was moving here, now in these lungs, this is an image of the lungs. Now look, when fluid collects inside the alveoli, this fluid moves outward, meaning fluid starts collecting within the lungs themselves. Due to this fluid collection in the lungs, when air enters the lungs and flows through, because of that airflow, if there's water here, a distinct type of sound is created, which we call crackles. So this symptom will also be crackles. another name for crackles. Instead of crackles, you might also see the term rales. And this question has been asked before, whether crackle sounds are heard in left-sided or right-sided heart failure. Additionally, another question asked was about a heart failure patient being given furosemide. The patient is receiving furosemide, so how will the nurse know the treatment is working effectively? The option provided was disappearance of crackle sounds. So if they disappear, if these crackle sounds have disappeared, it means the fluid here has started to decrease. The fluid has started to decrease, which is why when air flows through here, no crackle or rale sound is produced. So if the crackle sound has disappeared, it means pulmonary hypertension or pulmonary edema has decreased, meaning there's less water in the lungs. This means our furosemide therapy, that is, the diuretics we were giving to reduce fluid in the body, has started working. When water collects inside the lungs, because of that, meaning when fluid collects and air flows over it, a sound is created which we call a crackle, also known as a rale. I want to let you hear it once, see what it's like. So this is what a crackle sound is like. So you've heard it. That's a crackle sound. Now, crackles or rales, whenever they occur, they're associated with left-sided heart failure. Besides that, when we see more fluid accumulating here, due to that buildup in the lungs, the patient will develop sputum, which then enters the bronchi. If I draw the bronchi on this side, this fluid will move into them. So that means sputum will form. And what kind of sputum? If there's fluid here and air mixes with it, bubbles will form. It'll become frothy. This means the next symptom will be frothy sputum. But after that, if we assume the pressure from behind continues to rise, because of that increasing pressure, let's say the backward movement increases. Then pulmonary hypertension will escalate even further. And as pulmonary hypertension increases, these capillaries will eventually rupture. Up until now, there was only fluid here. But now, these capillaries have ruptured. Because of that rupture, the red blood cells inside them also leak out. Previously, the red blood cells were inside these capillaries, but now the pressure has increased significantly, meaning pulmonary hypertension has worsened, pulmonary edema has increased, causing the pressure here to rise and the capillaries to rupture. Due to the rupture, these red blood cells have come out. Now, besides fluid, there are also red blood cells here. Since there are red blood cells, the sputum produced will be pink or blood-tinged in color. Look here, if there are red blood cells, then when air mixes in, the resulting sputum will be pink. Pink, or it could be blood-tinged sputum. That means the sputum, which is the mucus you cough up from your lungs, might look pink because there's a small amount of blood mixed in. This can happen if your airways are irritated or inflamed, like from an infection or even from coughing a lot. Noticing pink or blood-tinged sputum is important because it can help your doctor figure out what's going on in your lungs or respiratory system. And this is a serious condition because we can now say that the patient's pulmonary hypertension is very severe. So this is another symptom of left-sided heart failure. In left-sided failure, we've seen that there will be pulmonary hypertension, congestion, and besides congestion, we also observed that sputum was forming in the patient. And this sputum was not only present, but it was also frothy in appearance. So in other words, we noticed frothy sputum. In addition to noticing frothy sputum, which is a bubbly or foamy kind of mucus that can be coughed up from the lungs, you might also see that the sputum is pink in color or even has a blood-tinged appearance. This means the mucus could look slightly reddish or streaked with blood, which is something important to pay attention to and mention to your healthcare provider. And crackles. Crackle sounds and rale sounds are both the same thing. So all of these were symptoms of left-sided heart failure. Now let's talk about the right side, because everything you saw was happening due to a problem in the left ventricle. So this means that the cardiac output will decrease in this case. That's done. Next, we'll see what problems the patient will face if there is right-sided heart failure. So the right side is this side here. Normally, after contracting in the ventricle, blood should be sent toward the lungs through the pulmonary arteries. But now, if the heart can't push it forward, the blood will flow back. When the blood flows back, it will enter the right atrium. Blood is coming from above, and blood is also here. Now watch as this blood goes back into the superior vena cava. The vena cava coming from above is called the superior vena cava. After going there, alongside the superior vena cava is the jugular vein. So look, this one here is the jugular vein. Now blood is also coming into the jugular vein from above, but now there's this backward movement from behind so that blood will also come. If blood comes from both sides, it means there will be congestion here. Fluid will increase, and as it increases, it will dilate. So from here, it means a symptom of right-sided heart failure will be jugular vein distension, meaning the jugular vein will become distended. Now, why did we write jugular vein distended? Why didn't we write that the superior vena cava is distended? Because we can't see it, right? It's deep. Whereas the jugular vein is superficial. So as soon as there's congestion or it dilates, it can easily be seen here that the patient's jugular vein is dilated. So the blood flowed back, causing distension in the jugular vein. After that, in addition to the blood normally coming from this side, there will also be backward movement. Congestion will also start to occur in our inferior vena cava because the blood flow in it will start to move backwards. Now look, in this inferior vena cava, blood is going up from one side, but some backward movement is occurring, which will increase the pressure in it. And due to the increased pressure, the fluid here will become congested because it was supposed to go this way, but backward movement started from this side, which has now increased the pressure. Increased pressure means this fluid cannot move forward. If it can't move forward, it means fluid will start accumulating here as well inside it. Now, when fluid starts accumulating from here, I'm talking about the inferior vena cava. A vein that is connected to the liver joins inside the inferior vena cava. I've drawn the liver here, and there's a vein connected to this liver, which we call the hepatic vein. Now, normally, this hepatic vein was supposed to pour the blood from here into the inferior vena cava. But while it is pouring it, because of the blood backing up from above, the fluid starts to have a bit of a backward movement as well. So what will happen is the pressure will increase and it won't be able to carry it up properly, and blood will start accumulating here. Now the blood coming from behind on one side, meaning it came out of the aorta, and after coming out of the aorta, it reaches the liver through the hepatic artery. So blood is coming from here, and from here the portal vein, meaning blood is also coming from the portal vein. And on one side, this blood is not moving forward, so that means the pressure will increase here. If the pressure increases here, it means the pressure in the liver will increase, the pressure in the liver's capillaries will increase. If the pressure increases here, it means fluid will now shift from the capillaries, it will leak from here. And when fluid leaks from the capillaries, fluid will enter the liver. And the size of the liver will increase. If the liver size increases, it means we call it hepato. The word used for liver is hepato, and the size increases. And increasing is called megalo, hepatomegaly. Okay, so this is hepatomegaly, which means the size of the liver has increased in this. If hepatomegaly occurs, it means the liver cells won't be able to function properly. If the liver cells don't function properly, then we can say that one job of the liver is to produce albumin. So albumin production won't happen either. And the job of albumin is, this albumin is a protein, and its job is to keep the fluid inside the blood vessels, meaning it maintains the fluid within the blood vessels. If there is no albumin, if the albumin protein is not there, then the fluid will come out of the blood vessels, meaning it will come outside the blood vessels. Because of that, there are chances of edema. So we can say that the albumin protein creates oncotic pressure. If the oncotic pressure in the blood vessels is low, then the fluid will shift and go into the tissues, which will cause edema. So in this condition, hepatomegaly has occurred, because of which the liver cells are not able to function properly. Due to this, albumin production does not happen. Because albumin production does not happen, there is now less albumin in the blood. Low albumin means a new problem has been created, so now the oncotic pressure has decreased. Decreased oncotic pressure means that it was albumin that was keeping the fluid inside these blood vessels, preventing it from leaking out unnecessarily. So now what will happen is that from wherever there are capillaries in the entire body, fluid will leak out and move out and shift into the tissues, which we call edema. Now, this fluid also enters the peritoneal cavity. So this means the accumulation of fluid within the peritoneal cavity is called ascites. So another problem has been created, and that is ascites. So ascites has occurred because of right-sided heart failure. Hepatomegaly has occurred because of right-sided heart failure. Now, as there is a deficiency of albumin protein, for example, this is the patient's leg. So the fluid will also leak out from the capillaries here. And as the fluid leaks out, it means fluid has now accumulated here within these tissues, which has caused edema in the patient. So this is edema. So these are all the symptoms of right-sided heart failure. So what all have we seen in right-sided heart failure? That is, whenever a patient has right-sided heart failure, we saw that first the jugular vein was becoming distended, so this is JVD, jugular vein distended. After that, we saw that the patient had hepatomegaly, which means their liver was enlarged beyond what is considered normal. This was an important finding during our examination. After that, we saw that ascites also occurred, meaning there was a buildup of fluid in the patient's abdomen, causing swelling. After that, the patient developed edema here, which refers to swelling caused by excess fluid trapped in the body's tissues. Each of these symptoms appeared one after another, helping us understand the progression of the patient's condition. So these are the manifestations of right-sided heart failure. This means you might notice things like swelling in your legs or ankles, or even some discomfort in your abdomen because of fluid building up. These signs happen when the right side of the heart can't pump blood as well as it should, so fluid backs up in the body. Now, with that in mind, let's get ready for what comes next. Watch for the real villain in heart failure. There are two villains. Although they act as compensatory mechanisms in the body, later they prove to be very harmful for the body, that is, for the condition of heart failure, as we have now seen the right and left sides. That those occurring on the right side will be these, and on the left side, they will be related to the lungs. So you can remember it this way. If it's right-sided heart failure, then systemic signs and symptoms will appear throughout the whole body. Whereas for the left-sided ones, just remember left. Left-sided heart failure starts with L, so it's related to the lungs. L for left, L for lung. So whenever there's left-sided heart failure, then the lungs will show related signs and symptoms. And when it's right-sided heart failure, systemic issues like edema will start appearing throughout the whole body. If I ask you if a patient has dyspnea, it's lung-related, so left-sided. If a patient has edema, it means right-sided. If a patient has nocturnal dyspnea, left-sided. And if a patient has ascites, right-sided. If there are crackles, if you hear crackles in the patient's lungs, then it's left-sided because it's lung-related. And if the patient has JVD, meaning jugular vein distension, then it's right-sided. If the patient has pulmonary edema or frothy sputum, if there's frothy sputum or pink sputum, it means it's lung-related, which are symptoms of left-sided heart failure. And if the patient has hepatomegaly, it means those are symptoms of right-sided heart failure. Now, after both this left-sided and right-sided, the real villain is our own body's mechanism, which we call the compensatory mechanism. Now, we saw that when, look at this. Let me just adjust the text a little bit. So now we saw that, first of all, as we saw, when the heart is unable to push forward properly, it means the body's cardiac output will decrease here. So less blood will enter the aorta. When less blood enters the aorta, what will happen next? Less blood in the aorta means less blood reaches the kidneys, and if less blood reaches the kidneys, they'll sense that cardiac output is low, or that the body's condition, or that the body is experiencing hypotension. So it initiates a compensatory mechanism. Before that, let me tell you one more thing. Whenever there's hypotension in the body, our sympathetic nervous system gets activated and enters a fight or flight state. In that state, our heart rate will suddenly increase. Look here. Cardiac output. I wrote these formulas so you could grasp the concepts clearly. As we saw in the diagram, less blood was being pumped out, meaning cardiac output is low. But if you look at the formula, cardiac output is defined as stroke volume multiplied by heart rate. This means if stroke volume is low, cardiac output will be low. And if heart rate is low, cardiac output will also be low. What our body thinks is that cardiac output is low. Our sympathetic nervous system thinks, why don't I increase the heart rate to compensate? When it increases the heart rate, what happens is that initially the heart rate in our body goes up. If the heart rate increases, since it's a multiplier, the cardiac output will also automatically increase. But while this increases cardiac output for a short time, the real problem remains. If, for instance, blood isn't being pumped out effectively due to a myocardial infarction, that underlying issue hasn't been resolved. So what will the heart do? The heart is already weak, yet it starts pumping faster and faster. Since it's already weak and now pumping rapidly, its workload increases. This increased cardiac workload means that it will quickly become exhausted. Later on, if this elevated heart rate, which initially boosted cardiac output, persists for a long time, it means that with a weak heart, if you force it to beat rapidly, the heart failure condition will only worsen. This is because increasing the heart rate doesn't treat the root cause. The root cause remains unaddressed, and on top of that, you've increased the heart rate. Because of that root cause, the heart is weak, and you're making a weak heart work harder by increasing the heart rate. Consequently, the heart will end up in even more trouble. Activation of the sympathetic nervous system will ultimately prove very harmful for a heart failure patient. So what do? We'll look at the management from here. Keep this in mind so that when we discuss the medical management and medications later, you'll understand why we choose certain drugs. We need to provide medications that target the sympathetic nervous system. Suppress it, meaning what will happen in that is it will suppress the heart rate, like beta blockers. They are given to everyone so that the activity of our sympathetic nervous system decreases, so the heart rate decreases and the extra workload on the patient is reduced. Besides right side heart failure and left side heart failure, another new problem was created in our body, which is the activation of the sympathetic nervous system. So let's write this down here as well, the activation of the sympathetic nervous system. Because of that, the heart rate will increase. If the heart rate increases, it means initially in the starting phase, it's fine. But if this persists for a long time, the cardiac workload will increase. And because of that, the heart failure condition will worsen. So this means we will also need to treat this later on. After that, we'll study what happens next whenever the cardiac output decreases. If the cardiac output decreases, the kidney thinks that the blood pressure in the body has dropped. So now, whenever the blood pressure in the body drops, the kidney activates a system, a series of events that we call RAS, which is the renin-angiotensin-aldosterone system. It activates this. What happens because of that? Because the kidney doesn't know that the heart is weak. The kidney thinks that the cardiac output is low. That means the blood pressure is low. So now it works to increase the blood pressure. How will it increase it? Look, I've drawn the liver here again. So now what will happen if the cardiac output is low? Then the kidney will think, look, this kidney will think that the blood pressure is low. This means we should now start the process to increase the blood pressure. Now, it thinks that if I retain sodium in the body and don't let it out through urine, then more sodium will stay in the blood. Water will follow the sodium. So if both water and sodium are retained together, the blood pressure will automatically increase. But in heart failure, we don't want this because it doesn't treat the root cause, right? The root cause hasn't been addressed. So now let's see what normally happens when the blood pressure is low. So our liver produces angiotensinogen. This is a protein, and this protein stays within our blood. You see, it's present in every single person, in all of us. But if the blood pressure happens to be low, then renin, which is an important enzyme, is produced by our kidneys. This renin, once released into the bloodstream, will act on a protein called angiotensinogen, which is made by the liver and circulates in our blood. Renin will convert angiotensinogen into a new molecule known as angiotensin 1. In other words, it will create angiotensin 1, which is the first step in a series of reactions that help regulate our blood pressure. So now the angiotensin 1 that is inside the blood vessels, this angiotensin 1 will reach the lungs through the blood. Until it reaches the lungs, it remains in an inactive state. This means it is not active. We can say it is not active because angio means blood vessels and tensin means to tighten. That is, tightening the blood vessels. Angiotensin 1 cannot perform this function, which means we can say it is in an inactive state. But as it reaches the lungs, see, these are the lungs here. So when it reaches the lungs through the blood, ACE is produced by the lungs. This substance, ACE, is produced right here within the lungs. So from here, ACE will emerge, which is angiotensin converting enzyme. Angiotensin converting enzyme. This angiotensin converting enzyme will now convert this angiotensin 1 into angiotensin 2. This angiotensin 2 that has been formed here, this is now angiotensin 2. Angiotensin 2 functions exactly as the meaning hidden in its name suggests, where angio means blood vessels, tensin means tight. Now, it will tighten these blood vessels further down the line, meaning it will cause vasoconstriction. This implies angiotensin 2 is in its active form. So angiotensin 2 tightened the blood vessels. It constricted them, which means blood pressure will increase. So the kidney sensed low blood pressure and decided to constrict the blood vessels, which it did. However, the actual causes of heart failure within the heart were different. Now the heart will have to pump even harder and exert more force because the blood vessels are already tight and constricted, meaning the blood pressure has increased. So with elevated blood pressure, the heart must pump even harder, which means the condition of heart failure will worsen significantly. This shouldn't have happened, anyway. After that, this angiotensin II will reach a gland located above our kidney called the adrenal gland, and it will trigger secretion from there. Aldosterone. As soon as angiotensin II reaches the adrenal gland, the kidney will begin to secrete aldosterone. And this aldosterone will be produced here. And within the kidney, as we know, there are many nephrons. I have drawn an image of one nephron here. On this collecting duct, there are principal cells. There are some cells here called principal cells, which are located on the collecting duct and the DCT. Now, aldosterone will come here, but what happened was that the ROS system got activated, meaning the renin-angiotensin-aldosterone system was activated. And because of that, our adrenal gland produced aldosterone. This aldosterone reached the nephrons inside the kidney. And within the nephron, it reached the collecting duct part. And on the collecting duct, many cells are found, which we call principal cells. It will reach those cells. What will happen is that it will reach those principal cells and activate them, then increase the reabsorption of sodium from there. Now, the blood that was being filtered into this filtrate, which was supposed to become urine later on, the sodium within it will start being reabsorbed again because of this aldosterone. Now, if it's reabsorbed, then these blood vessels of ours, meaning these blood vessels right here, the sodium will come back into these blood vessels because of aldosterone. If aldosterone is high, then more sodium is returning to the blood. It's not being excreted in the urine. So now, the more sodium that is coming here, the same amount of water that was in this filtrate, as through osmosis, as much sodium as comes in, the same amount of water will come in with it. So this means that from this filtrate, what will happen is water will also come inside. So from here, what will happen is these principal cells will also bring water into these blood vessels. Look, from here, water will enter into it. So the more water and sodium there is, the more the blood pressure will increase. Now, the kidney has done this as a compensatory mechanism. It thought the blood pressure is low, so let me increase the blood pressure, which it has indeed increased. But in a heart failure condition, we didn't want this. So that's why this RAS system proves to be like a villain. So that's why when when doctors treat this, then you might know this RAS system. So when doctors treat this, as you might know, they give medications that work on this RAAS system, such as ACE inhibitors. These include the pril medications like captopril, enalapril, and ramipril. They work on this RAS system, and they stop what was happening, that is, sodium and water going back inside, and prevent the BP from increasing. So that was it. Besides this, we had another problem where the renin-angiotensin-aldosterone system got activated. Because of that, what happens is sodium increases and water also increases in the blood. Consequently, BP, or blood pressure, also rises, which proves to be very dangerous in heart failure. Now, let's see what the management should be. So far, we've seen that in heart failure, fluid is mostly retained throughout the body, whether you consider the lungs or the entire body. This means we have a major problem, which is fluid retention. So whenever we talk about management, we have to look at that. So fluid retention. Fluid retention has become a very big problem in heart failure, so we will manage it accordingly. This happens in two places. One is fluid retention in the lungs, and the other is in the entire body. If it's left-sided heart failure, it'll be in the lungs. If it's right-sided heart failure, it'll be in the whole body. So now, first, we'll look at the management. What will we do? That is, we need to remove this fluid, so we'll give some medications. First, if we talk about management, what can we give the patient? If fluid is accumulating, we'll give medications that flush the fluid out. This means that, first of all, the patient is given diuretics. What will diuretics do? They'll flush out urine. If urine is flushed out, it means fluid is flushed out. If fluid is flushed out, less will accumulate in the lungs, and the heart will also have to work less. Consequently, the symptoms that were occurring, fluid collecting throughout the body, that problem will be resolved. So whenever we give diuretics to a patient, what do we need to do? When giving diuretics, you have nursing responsibilities. Many questions are asked about this. Often, a heart failure scenario is given along with diuretics, and you're asked about their specific roles. So loop diuretics are administered to the patient. Loop diuretics, they work going inside the kidney to the loop of Henle. Now, this kidney contains many nephrons, and we've drawn a diagram of one nephron here. So they work on the loop of Henle, which is why we call them loop diuretics. So loop diuretics work right here on the ascending loop of Henle. These loop diuretics block the cells here. There are sodium-potassium pumps here, like this channel or that channel, or what we can call sodium-potassium pumps, through which sodium and potassium enter. Now, what mostly happens in this part? Our loop of Henle is surrounded by a network of capillaries. Now, like this blood capillary here, what happens normally? If these sodium-potassium pumps are open, then sodium will enter the blood from here, and potassium will also enter. Both sodium and potassium will enter the blood. This means less will stay in the filtrate, and consequently, less will be excreted in the urine. But now, you must remember one thing. Whenever we talk about the ascending limb of the loop of Henle, this ascending limb right here, the sodium-potassium channels there, in that sodium-potassium pump, both, meaning when sodium goes in, potassium also goes in, okay? Whereas in other places, like the principal cells, meaning the principal cells in the collecting duct, it's the opposite. When sodium goes in, potassium comes out. So in the loop of Henle, when sodium comes in, potassium also comes in. But besides that, what happens? In other places where there are sodium-potassium pumps, when sodium comes in, potassium goes out. It's the reverse. You need to remember this to truly grasp the concept of diuretics. So what happens? Normally, the sodium in the filtrate enters the blood here, so less is excreted in the urine. Now, the loop diuretics we've given the patient will act right here. They work on the ascending part of the loop of Henle. Because they work on the loop of Henle, we call them loop diuretics. What they do is block the sodium-potassium pumps here. Now, if they've blocked these sodium-potassium pumps, it means the sodium that was supposed to enter the blood, meaning move from the filtrate into the blood. Filtrate means what has been filtered by the nephron and will eventually become urine. Now, sodium cannot enter from this filtrate because the sodium-potassium pump has been blocked. Loop diuretics have blocked it. Now that the loop diuretic has blocked it, sodium will be excreted. Sodium will now be excreted from here and will leave the body through urine. When sodium is excreted, it means water will also be excreted with it. And that's exactly what we wanted. This means blood pressure will decrease. If there's less water in the blood vessels, blood pressure will drop. But another problem will arise here, which is that the potassium that was supposed to go back into the blood, that potassium will also be excreted. In other words, both sodium and potassium will be excreted. So potassium will also leave with the urine. This means there will be a deficiency of potassium in the blood, and a deficiency of potassium is called hypokalemia. Since we don't want to reduce potassium, we want to reduce sodium, because if sodium decreases, water will also decrease with it. So our goal was to reduce sodium. But potassium also decreased because we administered loop diuretics. Loop diuretics like furosemide and torsemide, what will they do? Now, whenever we give loop diuretics to a patient, we must remember, so we've seen that loop diuretics work on the loop of Henle and block the sodium-potassium pump there. Because of that, sodium will be excreted and water will be excreted, but potassium will also be excreted because the sodium-potassium pumps here are special. In this case, both sodium and potassium enter together. It's not like sodium enters and potassium leaves, which happens elsewhere. So in this case, potassium will also be excreted with the urine. This means that whenever loop diuretics are administered or given to a patient, what are some examples of these medications? For instance, a patient can be given a medication such as furosemide, which is also known as Lasix, or another similar drug like torsemide, which is sometimes called Demodex. Now, what will be the nursing responsibilities here? We saw that when potassium is excreted, it means the patient could develop hypokalemia. Hypokalemia, the normal potassium level, although they might not ask directly in exams what the normal potassium level is, they might ask, given a patient's blood report with a certain potassium level, what should the nurse do? Therefore, you must know the normal lab values. So if you know whether it's hypokalemia, hyperkalemia, or a normal potassium level, The normal potassium level is 3.5 to 5.5 milliequivalents per liter. But if a patient is given furosemide or torsemide, which are loop diuretics, potassium is excreted as a result, which is why we call them potassium-wasting diuretics. So what will happen? The potassium level will drop. If the potassium level falls below 3.5, it means the patient will develop hypokalemia. And whenever there's an abnormality in potassium levels, you must remember that arrhythmia, cardiac arrhythmia, occurs. So this means the chances here are, if the patient has hypokalemia, it's possible that the patient might develop cardiac arrhythmia, which means a nurse's responsibility starts here, which is to keep the patient on cardiac monitoring. This means keeping ECG electrodes attached because by doing so, we'll be able to clearly see the changes in cardiac monitoring, specifically within the ECG that occurred due to hypokalemia. Besides, this is a diuretic, which means more water will be excreted. This means it's possible that the blood pressure might drop even lower than we intended, potentially leading to hypovolemia in the patient. There's also a risk of hypotension, so you'll now need to monitor the patient's blood pressure as well. In addition to blood pressure monitoring, the patient might also experience dizziness. So you must then tell the patient that whenever they stand up, they should perform what we call a slow position change. We can advise the patient to change position slowly to prevent orthostatic hypotension. So these are the roles. Furthermore, if there's a potassium deficiency, we must tell the patient to consume a potassium-rich diet. We'll provide a potassium-rich diet to prevent a deficiency. In a potassium-rich diet, we can include things like bananas, spinach, potatoes, oranges, and many others. You'll need to memorize this entire list because questions are often asked about which food items to give or avoid for a patient with hypokalemia. These are very important things you must remember. One thing is that whenever a patient has heart failure and is given digoxin for treatment, we then consider giving a loop diuretic. Sorry, we'll discuss that later. But let's look at one thing. When a loop diuretic is given in an amount exceeding the patient's actual need, or if we administer it as a fast push, what will happen? This furosemide reaches the cochlea inside our ear. If I were to unroll and straighten this cochlea, it would have a structure like this. And inside this cochlea, there are hair cells on top, like this. And the furosemide will start damaging these hair cells. As they begin to get damaged, the patient will experience tinnitus. That is, with tinnitus, the patient feels as if bells are ringing. Ring another bell in their ears, meaning it feels like bells are ringing for them. So whenever tinnitus occurs, we should assume that maybe furosemide is being given too fast. So to avoid this, we must give furosemide slowly as tinnitus can occur. This means furosemide can cause ototoxicity. Toxicity of what? Oto. Oto means ear. When there is ototoxicity of the ear, it means the patient will have tinnitus. So it means whenever we give a loop diuretic, that is, whenever we give furosemide or torsemide to the patient, it must be given slowly, okay? And you must remember one thing. Any drug that has IDE at the end, it means it's a loop diuretic. So that was that. But after that, another problem arises. Sometimes the heart can't push the blood well, so the patient is given digoxin so that it pushes well. But when digoxin is given to the patient, if there's a potassium deficiency, the chances of digoxin toxicity increase. This is asked very often. It's the most important concept, because if we give a loop diuretic along with digoxin, the loop diuretic will cause potassium to leave the body. Potassium will leave, meaning potassium deficiency, and due to potassium deficiency, digoxin toxicity will increase, which we don't want. And whenever digoxin toxicity occurs, you know that due to digoxin toxicity, the late sign is, which includes bradycardia. So bradycardia will occur. If even more bradycardia occurs, then the heart is already pushing less, then the condition will get even worse. So now, instead of loop diuretics, let's move on to potassium-sparing diuretics, because we'll have to reduce the fluid. Now, if we're reducing the fluid and giving digoxin, then instead of loop diuretics, we will then give the patient potassium-sparing diuretics. So now we'll give the patient potassium-sparing. Sparing means to save. So diuretics that will save potassium, among them is spironolactone. So these potassium-sparing drugs, where do they work? So let's go back inside that same kidney. Back to the nephron in the kidney. So in the nephron, the ones like spironolactone will act on the principal cells further down. Inside our nephron here, we have the PCT, the loop of Henle, and this is the DCT. So in this DCT, there are some cells here called principal cells. Potassium-sparing diuretics act on these principal cells. Now, what do? They will block them. Now, they'll block these principal cells. Normally, when these principal cells aren't blocked, what happens? The extra sodium from this incoming filtrate was being reabsorbed back inside, meaning it was sent into the blood capillaries. I'm talking about normal conditions where the sodium in the filtrate was moving inside, but as sodium moved in, potassium entered the filtrate and was being excreted. But remember these two things. In the loop of Henle pump, both sodium and potassium move inside together. But here, in the principal cells, if sodium goes into the blood, potassium enters the filtrate. They move in opposite directions. Normally, if there's excess sodium in the filtrate, to prevent loss, sodium enters the blood while potassium enters the filtrate and leaves the body. Now, what we need to do is, when we give spironolactone to a patient, it comes here and blocks these principal cells. And if it blocks the principal cells, then look, the sodium in this filtrate, as a result, will no longer be able to move inside anymore. It just stays outside and can't enter the cell at this point. The sodium in the filtrate can't enter the blood vessels now because the principal cells have been blocked. Now, if sodium doesn't go inside, what happens to it? It stays in the filtrate and is then excreted through the urine. Sodium is excreted in the urine, which is exactly what we wanted, for sodium to leave so water follows it. This resolves the fluid retention in the body caused by heart failure. But since these channels are blocked and sodium is excreted, sodium didn't move inside. This means potassium didn't come out into the filtrate, so the potassium will remain inside here. What will happen is potassium will stay within the blood vessels, so while sodium's being excreted, sodium didn't move in, meaning potassium didn't enter the filtrate. It didn't enter the filtrate. This means potassium stayed in the blood vessels. Then what happens? The potassium levels will become higher than normal. This means whenever a patient is given spironolactone, there is a risk of hyperkalemia. Okay, because some sodium enters here and some potassium exits, maintaining normal potassium levels. But spironolactone blocked this pump, it blocked the principal cell. As a result, sodium can't enter the blood. If sodium can't enter the blood, potassium doesn't enter the filtrate, meaning it can't be excreted. Some should have been excreted to maintain normal levels, but what happens here? Potassium will remain stored inside it. Potassium will now stay in the blood vessels, and what does that lead to? That is why we call this spironolactone a potassium-sparing diuretic. So it causes diuresis, excreting urine, but it spares the potassium. However, potassium might build up more than needed, which leads to hyperkalemia. So there is a risk of hyperkalemia in this patient. So we can say if hyperkalemia occurs, our responsibility remains the same. When giving spironolactone, we must watch for hyperkalemia. So what does that mean we will do now? Our nursing responsibility is once again the same. Cardiac monitoring is essential for the patient. So whenever a potassium-sparing diuretic is administered, what should we do? We will have a responsibility then as well, and that is cardiac monitoring. Cardiac monitoring means performing an ECG, keeping electrodes attached, and monitoring for ECG changes associated with hyperkalemia. What are those changes? P, this is the P wave, then the QRS complex, and then the T wave. We must monitor this T wave. If it becomes elevated or peaked, it indicates hyperkalemia. Therefore, the patient must remain on cardiac monitoring. Additionally, since it is a diuretic, we must monitor B pages along with BP. We must also measure the patient's weight. If there are chances of dizziness, then the patient might have orthostatic hypotension. And if the patient has orthostatic hypotension, it means we will tell the patient to change positions slowly. And in this, we don't need to give a potassium-rich diet because the potassium level is already elevated. After that, we'll talk about the next thing. What else we can give? We've already solved this problem. The fluid that was accumulating has been removed. Now let's talk about what the other problem was. The heart wasn't able to contract properly. This means the heart wasn't able to push well. So why not give the patient some medication that will help the heart push better? Digoxin is one of those. Now, digoxin comes in here, and questions are often asked about this. What digoxin does is it's a cardiac glycoside, and within the 3 layers of our heart, now this middle layer inside our heart, which we call the myocardium, it goes inside this myocardium. And in this myocardium, we have 3 channels that we call, this is the calcium channel. From here, calcium will enter, and this is the calcium-sodium exchanger, and this is the sodium-potassium. This will be the sodium-potassium channel, this will be the sodium-calcium exchanger, and this will be the calcium channel. Now, the more calcium that comes in from here, the more calcium there is inside, the better the heart fibers will contract. And the more calcium that stays inside, the better the heart muscle fibers will contract. This means we need something like, now what does digoxin do? Digoxin increases the movement of this calcium into the cell. When digoxin comes, it will come here and bind to the sodium-potassium pump. Once it binds there, potassium won't be able to go in, and if potassium can't go in, then sodium won't be able to go out from here. Now, sodium is coming in from here, but it's not able to go out. This means the sodium level will be maintained within the extracellular fluid and intracellular fluid. Now, sodium isn't going out here, then sodium won't come in from here. If sodium doesn't come in, then calcium won't go out, and if calcium doesn't go out, then that's exactly what we want. We want calcium inside the cell, meaning inside the heart's myofibers. And the more calcium there is, the better the fibers inside the heart will contract. And that's what we need because the heart isn't able to push well. It's not able to contract. So we want something that increases the force of the heart's contraction. And that will only increase when more calcium comes and attaches to these small muscle fibers, namely actin and myosin, and the heart contracts. Now, the force of the heart's contraction will increase, which means digoxin did all this work because digoxin came and attached itself to the sodium-potassium pump here. Because of that, all of that, calcium got stored inside, and because of that, the heart contracted well, so the force of the beat increased. So this means the force has now increased. We call an increase positive, and for force, the word used is inotropic, and for an action that occurred, we use the word tropic. So that means digoxin is a positive inotropic drug. After that, digoxin does one more thing. In this condition, we saw that when our sympathetic nervous system was activated, because of that activation, the SA node was generating more beats, more impulses, which caused tachycardia. We studied that at the beginning, right? So to reduce that tachycardia, this digoxin, the first thing it did was its positive inotrope function. The second thing is that inside our heart, this SA node, whenever the sympathetic nervous system is activated, it generates a lot of impulses. And because of that, the heart rate increases significantly, which we don't want because the cardiac workload will increase. Now there are nerve fibers here of the sympathetic nervous system. So digoxin has made it here. When digoxin comes here, then on this SA node, acetyl is formed here, acetylcholine. And this acetylcholine, the more acetylcholine is formed, the fewer impulses will be generated. So that means the heart rate will now decrease here. We measure heart rate in time, and in time, because how many beats occur in 1 minute, is what we call heart rate, meaning 60 to 100 beats per minute in 1 minute. This means we measured it in time. The word used for time is chrono. And what did it do to the heart rate? It decreased it. It decreased it, which means negative for decrease and positive for increase. So this became negative chrono, and causing an action is what we call tropic. So this means digoxin is negative chronotropic, meaning it will decrease the heart rate. And we also want the heart rate to decrease because that will reduce the load on the heart. Digoxin is given in conditions like, say, atrial. We studied the cause at the beginning, one of which was atrial fibrillation. What does atrial fibrillation mean? It means that in the atrium, instead of the SA node, impulses start generating from everywhere along the atrial wall. If impulses start generating from everywhere, what will happen? If impulses start generating from everywhere and then they are transferred forward through the AV node, if these impulses are conducted, then the ventricles will also contract rapidly. Because of that, the ventricles won't be able to fill, so cardiac output will decrease further, meaning the heart failure condition will worsen. But if we give the patient digoxin, then because of digoxin, acetylcholine is produced here, which means the nerve impulses being generated here will decrease. Now, if they decrease, it means the heart rate will decrease. And because of this, acetylcholine is produced here, meaning the nerve impulses being generated will decrease. If they decrease, it means the heart rate will slow down. And from here, conduction, it means the heart rate will decrease from here. Besides that, what it does is that this AV node, this was the SA node, this is the AV node. So digoxin also reduces the conduction of these impulses through the AV node. It slows it down. It reduces it. So this means if there is atrial fibrillation, those signals, those impulses are no longer reaching the ventricles because of the digoxin. They aren't getting through. This means in a condition like atrial fibrillation, it's possible that a heart rate of 200 or 250 could be generated. But now, if we've given digoxin to the patient, conduction won't happen from here. If conduction doesn't happen, there won't be any effect on the ventricle. The ventricle will the heart rate inside the ventricle won't be that high, which is what we want, to keep it low so the ventricle can fill properly. Now what happens? It also reduced conduction. The word used for conduction is dromo. The word used for conduction is dromo. It's been reduced, and reduced is called negative. And since an action occurred here, some work was done, it's called tropic. So when we give digoxin to a patient, it's a cardiac glycoside, and it has 3 actions. It's a positive inotrope, which increases the heart's contraction, the contraction or the force, and it increases its force. That is, whenever it increases the force, it's a positive inotrope so that the force increases so that when there's if there's a strong force in it, more blood will be pumped out, which is what we need in heart failure conditions. It's a negative chronotropic, which means it reduces the heart rate so that conditions like ventricular tachycardia or atrial fibrillation can also be resolved. And negative dromotropic, meaning it reduces conduction so that the excess signals created in atrial fibrillation don't reach the ventricle. So now a major responsibility arises here. When the heart rate decreases, whenever a patient's heart rate drops, it shouldn't drop so much that the patient develops bradycardia. Therefore, whenever digoxin is being administered to a patient, the nurse's primary responsibility is to check the apical heart rate, to check the apical pulse. Where is the apical pulse checked? This is the clavicle bone. So from the middle of the left clavicle bone, we have to imagine a line going down. And then below the nipple, that is, at the 5th intercostal space, coming down there below the nipple, and both here, that's where our apical pulse is located. In other words, this mid-clavicular line of ours, this clavicle bone, take a line from the middle, which is called the mid-clavicular line, and just below the nipple at the 5th intercostal space, that's where our apical pulse is. And it must be checked for 1 full minute. This is the nurse's primary responsibility when digoxin is being administered. This question is often asked, what should a nurse do if a patient's heart rate is 50 while on digoxin? To answer that, we must see that since it's a negative chronotropic, it lowers the heart rate, and if it drops too much, it could cause bradycardia in the patient. So remember that for an adult patient, if the heart rate is less than 60, we must withhold the digoxin. This question is very common. If the patient is a child and the heart rate is less than 70, we must withhold the digoxin. If the patient is an infant and the heart rate is less than 90, then we must withhold the digoxin. Next, we saw that within the 3 layers of the heart, the middle layer, called the myocardium, contains cells. In those cells, we saw a pump, actually 3, calcium, then the calcium-sodium channel, and then the sodium-potassium pump. Whenever we give digoxin to a patient, it'll come and bind right here on this pump. Digoxin, which I'm labeling as D, will bind to this very pump. But here, there's competition between digoxin and potassium. Both digoxin and potassium will try to bind to the same site. If potassium, labeled as K, is already bound and there's only a little space for digoxin, it will work as intended. But if the patient has a potassium deficiency, like if we're giving furosemide, which is a loop diuretic causing potassium loss, then in that case, potassium won't be available. This means that the sodium-potassium pump is now completely open, fully exposed, and accessible to digoxin. So as a result, all of the digoxin molecules present will bind to it excessively, much more than usual. If digoxin binds to the pump more than it normally should, then what happens next? Well, that's exactly when the risk of toxicity or harmful effects starts to increase significantly. In other words, the more digoxin binds, the higher the chance of experiencing toxic side effects. Normally, we want potassium on this sodium-potassium pump, so digoxin doesn't bind unnecessarily. But with a potassium deficiency, the entire pump is open, so too much digoxin binds, leading to toxicity. That's why when giving digoxin, monitoring potassium levels is crucial. You must check for normal levels. So it's essential to maintain levels between 3.5 and 5.5 milliequivalents. When we give digoxin to a patient, we must provide a potassium-rich diet. This diet includes things like bananas, spinach, oranges, and potatoes. You need to keep this in mind. So that covers digoxin. Beyond that, the most frequently asked questions are about the signs and symptoms of digoxin toxicity. How will a nurse know if a patient has developed digoxin toxicity? Suppose we've given digoxin to a patient and this digoxin enters the bloodstream. I'm drawing the blood vessels here. In these blood vessels, the normal level should be between 0.5 and 2 nanograms per deciliter. If it's over 2 nanograms per deciliter, there's a risk of digoxin toxicity. If the level exceeds 2 nanograms per deciliter, what happens? If this level is high in the blood, it reaches a center in our brain called the CTZ center, also known as the chemoreceptor trigger zone. So the blood will reach this point, and once it reaches the CTZ center in the brain, it senses that the levels have reached toxicity. Now, this CTZ center is located very close to another center, the vomiting center. It sends a signal to the vomiting center to induce vomiting because there's a toxin in the blood. The goal is to expel the contents of the stomach so no more is absorbed into the blood. So what happens next? The vomiting center sends signals to the stomach, the diaphragm muscles, and the abdominal muscles to trigger vomiting and clear out the stomach contents. This prevents further absorption from the stomach so digoxin levels don't rise further in the blood. This means the first signs and symptoms, and this is a very common question. The early signs of digoxin toxicity are GI related, meaning they involve the gastrointestinal system. So whenever digoxin toxicity occurs, there will be nausea and vomiting. In addition, anorexia will occur. Anorexia means a loss of appetite, so the patient won't want to consume anything else. This is because the body senses a toxin and tries to prevent further intake. So what it does is anorexia, nausea, and vomiting are early signs. Besides that, the digoxin we gave the patient reaches the eye. This is the eyeball. Like this is the eyeball and this is the eye. So the innermost layer of this eye, which we call the retina, this retina also has sodium-potassium pumps, and it blocks those sodium-potassium pumps again. That is, it also blocks the sodium-potassium pumps on the retina, digoxin. Because of that, the cells of the retina The sodium-potassium maintenance that should have happened, meaning the level that should have been maintained, becomes imbalanced. This means there's an electrolyte imbalance, and as soon as there's an electrolyte imbalance, the image formed by the retina, or the visual signal that goes to the brain, will be distorted. It will be distorted, which means the patient will have blurred vision. And besides that, the patient might also see a yellow halo around objects. So these eye-related symptoms will also appear in the patient. When the patient has digoxin toxicity, it means the next symptoms the patient will have will be eye-related, which will include blurred vision. And yellow. A soft halo around, Objects. Halo means that around any object, for example, if this is a ball, the patient feels like there's a yellow halo around the ball. So this is called a yellow halo around objects. Besides this, the patient also gets cardiac, neurological symptoms. So neurological symptoms will occur. And finally, the patient gets cardiac symptoms, which can include bradycardia. So bradycardia is the latest symptom. This means the toxicity could be very high. So whenever the patient has nausea and vomiting, we should understand that digoxin toxicity might be occurring. If the patient has digoxin toxicity, what do? We give a drug called Digibind. So this will be Digibind. This is the antidote. The antidote for digoxin is Digibind. So we've seen up to here. Now, after this, we saw one more thing. If the patient's blood pressure is high, the chances of cardiac heart failure also increase. So in that condition, what we'll do is give the patient medication that lowers their blood pressure. And we saw that. We also saw one thing, that the formula for blood pressure is cardiac output times systemic vascular resistance times heart rate. Meaning, whenever a patient's blood pressure is high, the heart failure condition will worsen even more. And what is blood pressure related to? Meaning, if cardiac output is high, blood pressure will be high. If cardiac output is low, blood pressure will be low. Systemic vascular resistance, meaning if the resistance of the blood vessels is high, then BP will be high. If systemic vascular resistance is low, it means the blood vessels will be dilated, so BP will be low. If the heart rate is high, the chances of BP increasing will be higher. If the heart rate is low, it means BP will also decrease. To lower the heart rate, now we give the patient medication called beta blockers. Beta blockers will go inside the heart and act on the SA node. And these beta blockers, they will act on the SA node. They'll go and act on the SA node and block them. Inside our body, there are two types of receptors, two types of beta receptors. One is beta 1, and the other is the beta 2 receptor. Beta 1 receptors are located in the heart, and beta 2 receptors are located in the lungs. You can remember it like this. There's one heart, so that means beta 1 receptors, and there are two lungs in the body, so that means beta 2 receptors. Now look, the medication we give, beta blockers, what they do is block these beta receptors. This means they'll act on the heart and also on the lungs. Beta blockers go into the heart and act on the SA node. Now we have two types of drugs here. One is cardioselective and one is non-selective. Non-selective means we now have two types of beta blockers. The first one is non-selective. Non-selective means there's no selection involved as to whether they'll act on the heart or on the lungs. They act on both. This means they're non-selective, so they'll act on both beta 1 receptors and beta 2 receptors, working to block both of them. This means they'll also act on the heart, and by acting on the heart, they'll lower the heart rate. And they'll also act on beta 2 receptors, which means they'll act on the lungs too. And in the lungs, they'll narrow the bronchi. They'll narrow the bronchi, which means they make the airway smaller and harder to breathe through. Examples of these non-selective ones include timolol, as well as others in the same group. And propranolol. Any drug that ends in LOL is a beta blocker. But even among beta blockers, we have two types. One is non-selective, meaning it's not for one particular receptor. It's non-selective and will act on all beta receptors. So that means it'll act on both beta 1 and beta 2. When they act on beta 1, meaning when beta blockers are given, they'll block the beta 1 receptors, which means they'll block them inside the heart. So they'll lower the heart rate, and at the same time, they'll also act on the lungs, meaning they'll block the beta 2 receptors as well and go there to narrow the bronchi. Now, a question was once asked here about a patient who has a patient who has heart failure, and in that case, the patient is being given these drugs, but the patient also has asthma. So which drug will the nurse question the doctor about? There were several options, like Timolo, and besides Timolo, there were two drugs that didn't act on the lungs despite being beta blockers, like atenolol and metoprolol, so all three are beta blockers, and one more drug was given. So the answer we had to give was that if a patient has heart failure and also has COPD, then if we have to give a beta blocker to lower their blood pressure or heart rate, give a beta blocker that only acts on the heart, not one that acts on both. Because if you give one that acts on both, it means it will lower the heart rate, but also act on the lungs. And in the lungs, they will also narrow the bronchi. Due to the narrowing of the bronchi, the asthma condition will worsen even more in the patient. So therefore, it means we can say that for a patient who has COPD or asthma, if we need to lower the heart rate or BP, or if we need to give a beta blocker, we will avoid the non-selective ones because what they do is they also affect the lungs, meaning they will block the beta 2 receptors as well. This means they will cause narrowing of the bronchi, which can cause more problems for patients with COPD and asthma related to respiration. Then what happens is we have another option, which we call cardioselective beta blockers. After that, we have cardioselective beta blockers. Now, as the name suggests, they will block the beta receptors, and cardioselective meaning they will specifically block those in the cardiac system, that is, in the heart. This means they will only act on the heart and not on the lungs. This means they will act only on the beta 1 receptors. They will block the beta 1 receptors. This means they will only lower the heart rate. So this means they are given to heart failure patients who, for example, also have COPD. We give these drugs. Which ones are included? Atenolol, and metoprolol. So you must keep this in mind. If you're giving a beta blocker to a patient, you also need to check in the question if they have COPD or asthma. If they have COPD or asthma, you must give medication that only works on the heart, okay? So these other ones, the non-selective beta blockers like timolol and propranolol, we consider them contraindicated in COPD and asthma. This question is asked very often, so there's no need to be confused here. Now, regarding the nurse's responsibility, we'll see that if, say, it's working on the SA node, it means it's reducing the heart rate, so the patient could also have bradycardia. This means whenever the patient's heart rate is less than 60, we'll withhold it. It's also lowering the blood pressure, which means if the systolic blood pressure is less than 90, we'll withhold a beta blocker. Along with that, for those hypotensive drugs, we need to measure, meaning we'll measure the blood pressure and we'll tell the patient to change positions slowly because it's possible the patient might have chances of orthostatic hypotension. So now we've given this medication, which means the problem we had in heart failure, like the heart was pumping less, it was pumping less. So for that, we gave the patient Digoxin because it's a positive inotrope, so it increased the force of the beat. Besides that, if the sympathetic nervous system was activated in the patient, the heart rate was increasing because of that, which we don't want. So to reduce that, we gave the patient beta blockers. Besides that, there was fluid retention in the patient. Fluid retention. For this fluid retention, we've given diuretics, so we've done this so far. Besides that, what other condition was occurring in the patient? If the blood pressure is high, there are still chances of heart failure, right? Blood pressure is high, so it means there are chances of heart failure. Now, for blood pressure, we'll give different medications based on its formula. For example, if blood pressure is high, what can we do? What was its formula? Cardiac output times systemic vascular resistance times heart rate. So we've reduced the heart rate with beta blockers. This systemic vascular resistance means that our blood vessels are contracted, and if this decreases, it means systemic vascular resistance will be low, which means the blood vessels are dilated. If the blood pressure is high, there's hypertension, and because of that, the patient has heart failure. Then what will we do? Now we'll give them this antihypertensive drug. For that, what will we have to do? Like if we reduce this, meaning we reduce the vascular resistance, then it means we have to give, meaning we have to cause vasodilation. So for this, we'll need to induce vasodilation, and inducing vasodilation means we have to administer a vasodilator. So it's possible we might give the patient nitroglycerin. Give it. What nitroglycerin does is it dilates the blood vessels throughout the entire body, whether it's in the heart, the brain, or anywhere else in the body. So whenever the blood vessels dilate, it means the blood pressure will decrease. Besides this, what we do is give the patient CCB. CCB meaning we give them calcium channel blockers. Now here we'll give them CCB, calcium channel blockers. But what do calcium channel blockers actually do? You can see from the name, they'll block the calcium channels. If they block the calcium channels, and if the calcium channel is inside the heart, then what will happen in the heart? In our middle layer, which we've called the myocardium. Now, inside that myocardium, the calcium channel that exists, like we saw here, the calcium channel. So there's a calcium channel, a calcium-sodium channel, and a potassium-sodium channel. So now, if potassium comes in from here, then sodium goes out from here. Now, if sodium goes out from here, it means sodium has come in from here, and calcium has gone out from here. Now, this is the calcium channel. Only calcium comes in through here. If we give the patient a calcium channel blocker, it'll block this calcium channel. I'm talking about the heart. So if it blocks this, then calcium won't be able to go inside. It'll just stay in the extracellular fluid and won't be able to come in here. Now, this means if we talk about the myocardial cells inside the heart, if calcium doesn't come inside, then it means these fibers inside, the actin and myosin ones, only when calcium reaches them can they cause a contraction with good force. But if we've blocked the calcium channel itself by giving CCB, then what will happen is they won't be able to push effectively. But that's not what we want, because in a heart failure condition, we need medication that pushes well, right? So that's why whenever we give a patient calcium channel blockers, we give the kind of medication in the calcium channel category that doesn't act on the heart, meaning it doesn't block the calcium channels inside the heart, but instead blocks the calcium channels inside the blood vessels, specifically the arteries. So this means we want it not to act on the heart that was here, but it does happen. Among these, all the drugs within the calcium channel blocker, or CCB category, are divided into two categories. One type is those that also block the calcium channels inside the heart, as well as the calcium channels within the arteries. That is, this calcium channel is found in both places, and it's found here as well. So that means they will block calcium channels in the arteries as well as in the heart. Now, if the calcium channels in the artery are blocked, it means there won't be any contraction here. No contraction in the artery is exactly what we want. If there's no contraction, the artery will dilate. Artery dilation means the systemic vascular resistance will decrease, which means BP will drop, blood pressure will drop. And this is good for our patient. So we want the arteries to dilate, but we don't want the force of contraction in the heart to decrease. We don't want that. We want the force of contraction to increase to boost cardiac output. But as cardiac output increases, the resistance for it to move forward should be low, meaning the artery should be dilated. So that's why we give the patient calcium channel blockers, so that they will enter the arteries. The same thing happens in the arteries. They block the calcium channels. And if the calcium channels are blocked, the muscle fibers won't have calcium. Without calcium, they can't contract. If they can't contract, the artery won't be able to contract properly. It won't. This means it stays dilated. Staying dilated is good for heart failure patients, meaning the BP will stay lower. But among all the calcium channel blockers, there are some like verapamil and dilti and diltiazem. These two calcium channel blockers work on the heart as well as here on the arteries. And this question was once asked, something like, can we give the patient, the wording might have been different, maybe the sentence was different, but the point was a heart failure patient who is acute, meaning they just had heart failure, haven't recovered yet, and aren't stable. The patient is unstable right now. At that time, the doctor prescribed verapamil. So what question would the nurse ask? I mean, it was in the options which drug the nurse would question. So verapamil was there along with other drugs like digoxin. We can give digoxin. Then there was atenolol. The options might change, but one of these two was there. So what happened is students thought, we'll give a calcium channel blocker because it lowers blood pressure. So verapamil, and that's where students got it wrong. This is how they trap you. So suppose I give you 4 options for a heart failure patient, and to lower the blood pressure, the doctor prescribed several medications. In addition, the heart failure patient is on these drugs: digoxin, verapamil, atenolol, and furosemide. So which of these drugs will the nurse question the doctor about, asking why they were prescribed? Now, what does students think? They think digoxin is fine, but for verapamil, they think it's a calcium channel blocker, so it'll lower BP, and we need to lower BP anyway. So that means they get confused by this question. However, you had to see that for calcium channel blockers, we can only give drugs that don't act on the heart, but only on the arteries. This means that verapamil and diltiazem act on both, so you should exclude both verapamil and diltiazem. Apart from those, we can give all other calcium channel blockers in heart failure when the patient is unstable. Because if we give these in an unstable condition, they'll also act on the heart and block the calcium channels inside. Calcium won't be able to enter, and then the ventricles won't be able to contract properly. In heart failure, the issue is already that it couldn't contract or push blood effectively, right? So now it won't be able to push the blood even more. So remember, calcium channel blockers can be given, but verapamil and diltiazem should not be given to unstable patients. Besides this, we studied one more thing. So we're done with this, meaning we've addressed the BP. There was one more condition we studied at the beginning, where we said that the compensatory mechanism, which is normally good for the body, makes the patient's condition even more serious in heart failure. That was the activation of the RAS system. When the RAAS, or RAS system, was activated, what problem did it create? Sodium was retained in the body. Water was being retained, which means there will be fluid retention. So now we need to give some medication that suppresses this RAS system itself. So what do we need to do for that? Let's look at the RAS system once again. There's nothing much to it. Normally, what happens in our bodies is, for example, this is the liver. From this liver, angiotensinogen is produced in the body. This substance, known as angiotensinogen, continues to circulate throughout the entire body, moving through the bloodstream. However, if the blood pressure happens to be low, then when the blood eventually reaches the kidneys are able to sense this drop in blood pressure. In response to this, the kidneys begin to produce an enzyme called renin. As soon as renin is produced and released into the bloodstream, this angiotensinogen undergoes a transformation and changes into a new form called angiotensin 1. Once it is changed into angiotensin 1, the process continues from there. Now, for angiotensin 1, angio means blood vessels, and tensin means tight or constrict. But it can't do that, which means it's in an inactive form. Now this blood moves forward, and going further, this blood reaches the lungs. So these are our lungs. So this blood will now reach the lungs, and as soon as it reaches the lungs, ACE will be produced, which is angiotensin-converting enzyme, an enzyme that converts angiotensin 1 into angiotensin 2. So now this ACE will come here. As ACE entered the blood, angiotensin 1 has been converted into angiotensin 2. Now, as soon as angiotensin 2 was formed, it starts working exactly as its name suggests. Angio means blood vessels, and tensin means it starts to constrict them. This is where the whole story begins. So now, all the blood vessels throughout the body will become constricted. They will constrict like this, which means the blood pressure will increase. Now, this is fine in a condition where the body's blood pressure is low, but if the blood pressure isn't low and this still happens, it can prove to be very serious for our body in a heart failure condition. So from here, the blood vessels have constricted. Besides that, this blood, this angiotensin, will reach our adrenal gland, which is the gland located right on top of the kidney. Now it will reach this adrenal gland, and from here, it will trigger the adrenal gland to secrete aldosterone. As soon as it triggers the secretion of aldosterone, this aldosterone will reach the kidney. And aldosterone reached the kidney. So inside the kidney, it'll reach the DCT and the collecting duct right here. Now, what it will do is increase the reabsorption of sodium, meaning it will put sodium back into the blood. If sodium enters the blood, it means more water will also enter the blood, leading to hypertension. Normally, this condition would be fine if the blood pressure were low, but in a heart failure condition, it'll cause even more problems. So now we need some meds. This is what we call RAS, or ROS, which is the activation of the renin-angiotensin-aldosterone system. In a heart failure condition, we need to depress this system, meaning we shouldn't let it activate. So where did the actual condition start? Where did the vasoconstriction begin? And where did the sodium production, the sodium reabsorption start? All these steps happened because of this ACE. Why don't we just stop this ACE? If this ACE isn't there, meaning if the angiotensin converting enzyme isn't present, if ACE isn't there, then angiotensin 2 won't be formed. If angiotensin 2 isn't formed, well, angiotensin 1 is already inactive anyway. It can't do anything on its own. So now, if there's no angiotensin 2, there will be no vasoconstriction. If there's no vasoconstriction, the blood vessels will remain dilated. This means that in a heart failure condition, the heart will be able to pump blood out effectively. So that's one problem solved. Besides that, the aldosterone being produced here won't be made either, because aldosterone is also produced due to angiotensin 2. So now we'll give some medication that stops ACE, which is angiotensin converting enzyme, from being produced. Then all of these problems will be resolved. So what can we give for that? To stop the ACE being produced, we'll give a drug that blocks it. Just like its name, we'll just add inhibitor to the end. Something to stop ACE, which means we'll give an inhibitor. Now, once an ACE inhibitor is given, ACE won't be produced here. If it's not produced, it means blood pressure won't rise, vasoconstriction won't occur, and aldosterone won't be made. If aldosterone isn't made, sodium reabsorption won't happen. Without sodium reabsorption, water won't be absorbed, and without water absorption, there won't be fluid retention in the body. But another problem arises. If you're using any question bank or solving questions from any book, you might have seen a question that asks, what happens when a patient is being given captopril or lisinopril? What will be the side effect for that patient? What's the main complication? What's the side effect? It's a dry cough. Why does that happen? It's because when we give a patient an ACE inhibitor, it causes a dry cough. This question has been asked before. So now let's take a closer look at ACE inhibitors. What are some examples of these medications? Well, drugs that end in pril, such as lisinopril and captopril, are good examples. These medications all fall under the category of ACE inhibitors. ACE inhibitors. Now, once we've given these to the patient, what will they do? They'll inhibit ACE, and because of that, all the problems will be resolved. But when ACE, or angiotensin converting enzyme, is present in our body, what happens? It's actually good for our body too. Suppose a substance called bradykinin is circulating in our body. bradykinin. This bradykinin substance circulates throughout the body within the blood vessels. Now, what ACE does is it damages or breaks down the extra unnecessary bradykinin, which is healthy. But if there's no angiotensin-converting enzyme in our body, then the bradykinin will keep increasing. Now, see, this bradykinin will increase. There will be bradykinin everywhere in the blood vessels. Then this bradykinin will also go into the lungs, and it will enter the lungs. When this extra bradykinin goes into the lungs, and when this goes into the lungs, there are cough receptors here in the lungs. These cough receptors will be irritated by this bradykinin, and when they are irritated, the patient will have a dry cough. So this means that the dry cough that was occurring is because of this bradykinin. So this means when we give lisinopril or captopril to the patient, the production of angiotensin-converting enzyme will stop. Once that stops, then to break down bradykinin, nothing is left. So this extra bradykinin that keeps forming will enter the lungs, and once in the lungs, it will irritate the cough receptors and produce a dry cough. This has been asked before, and that for all the pril medications, bradykinin is a side effect. Besides this, one thing we also need to see is whether the patient will have hyperkalemia or hypokalemia. Whenever we are giving lisinopril and captopril to a patient, we have to see if hyperkalemia or hypokalemia occurs. So what happened here is that it inhibited the angiotensin-converting enzyme, and because of that, aldosterone was not formed either. Since aldosterone wasn't formed, sodium is being excreted. These principal cells inside the nephrons of our kidneys. Now, normally what happens is that when aldosterone is formed, because of the aldosterone, sodium from these principal cells will enter the blood vessels. These blood vessels, say small capillaries, so sodium came back into them because of aldosterone. Aldosterone increases sodium retention. It will increase reabsorption, so it came from here. And now you have to remember that when sodium goes in, potassium comes out. So potassium came out, meaning it enters the filtrate. Once in the filtrate, it's excreted from the kidney via urine. But if we've given angiotensin-converting inhibitors, namely lisinopril and captopril, then aldosterone wasn't formed. No aldosterone means sodium reabsorption didn't happen, so sodium didn't enter the blood. Since sodium didn't enter the blood, it means potassium didn't go out, and since potassium didn't go, it means potassium stayed in the blood vessels, and since potassium stayed in the blood vessels, it means the potassium level will increase. This means whenever we give lisinopril and captopril to a patient, there will be chances of hyperkalemia, so this means ECG monitoring is now necessary for the patient. We should look for the chances of hyperkalemia as a side effect in them. If the patient has a dry cough and we need to give them medication that stops vasoconstriction and prevents sodium reabsorption, we can't give them ACE inhibitors like lisinopril or captopril. This is because the patient already has a dry cough, and if we keep giving these, bradykinin will keep forming, go into the lungs, and continue to irritate them. It will irritate those receptors, the cough receptors, and the cough will only get worse. So what can we do now? Well, what we can do is not give the patient an ACE inhibitor. If we don't give an ACE inhibitor, it means ACE will be produced in the lungs, meaning angiotensin-converting enzyme will be present. Once that enzyme is formed, it will convert angiotensin 1 back into angiotensin 2. This means angiotensin 2 will now be produced. So what will it get on? It will go on to cause vasoconstriction and will also trigger the secretion of aldosterone here, leading to sodium reabsorption. But we don't want that to happen. We need to stop both of these things. We must prevent vasoconstriction and also stop aldosterone production so that sodium doesn't enter the blood. So what we do is, while aldosterone is circulating in the blood, our blood vessels have these receptors. These receptors are exactly where that angiotensin 2 will act. If we block these angiotensin 2 receptors, then no matter how much angiotensin 2 is in the blood vessels, it won't be able to constrict them. Similarly, on the adrenal glands above our kidneys, there are also receptors that sense angiotensin 2 and then trigger the next steps. We also call these angiotensin receptors. They are angiotensin receptors. So this angiotensin II would act on them, and only then would aldosterone be produced. That's how it works with angiotensin II. This is angiotensin II, and these are its receptors. It must attach to these receptors to cause vasoconstriction. Over here, angiotensin II must attach to these angiotensin receptors to trigger aldosterone secretion. So why don't we give a different medication? Since we can't use an angiotensin-converting enzyme inhibitor because of the patient's dry cough, why not give something that stops this angiotensin II from working altogether? So now we'll give a medication that comes in and blocks these receptors. It will block the angiotensin receptors from the front. We've now given a medication that has successfully blocked these receptors. Now, if these receptors are blocked, even if angiotensin II is present, it simply won't be able to function. Without that function, vasoconstriction won't occur. Similarly, once we've given angiotensin receptor blockers, they block these angiotensin receptors. With the receptors blocked, angio2 can't act, so no aldosterone is produced. So this means sodium reabsorption didn't happen. These drugs are what we call ARBs, which stands for angiotensin receptor blockers. Losartan is one of these drugs. So that covers everything about which drugs we can give to heart failure patients and what the nurse's role would be in this. Now, look, we've seen all these drugs. For the Ross system, we give two types of drugs. First, we'll give ACE inhibitors. And if the patient has a severe dry cough or hyperkalemia, then we can give them ARBs, okay? Angiotensin receptor blockers. So we have to give all these medications to the patient. Along with that, the nursing roles are very important. In heart failure is a very important topic, a huge topic, and many questions are asked about it. Besides that, other responsibilities include restricting the patient's fluid intake. Fluid restriction means we won't give the patient more than 2 liters of fluid a day. In addition, weight monitoring is very essential. Daily weight monitoring must be done. If daily, for a heart failure patient, you have to weigh them every day. If there's a weight gain of 2 pounds per day, inform the doctor. Or not 2, sorry, let's say 3 pounds per day. Consider 3 pounds per day. If there's a weight gain, it's a bad sign for a heart failure patient. In this, or if 5 pounds per week of weight is gained, we still need to inform the doctor. Besides that, we need to restrict sodium in the diet. Sodium, a restricted diet must be given. A sodium-restricted diet. In that, we won't give any canned foods, meaning any food that comes in a can. Canned foods like pickles or canned beans. We won't give these to the patient. This question was once asked, whether pickles can be given to that patient or not. Since they contain sodium, they can't be given. Besides that, processed foods won't be given. In addition, packaged foods, the ones that come in packages, we won't give those either. So any high sodium diet, like chips or roasted meat, which has a lot of sodium, we will avoid those things. Besides that, we won't give the patient things like sauce. We won't give any of these things. So we will avoid things containing sodium. Besides that, a nurse has a very big responsibility because the patient is experiencing dyspnea. When the patient has dyspnea, we will give the patient the Fowler's position or the high Fowler's position. Due to the high Fowler's position, all the fluid will shift to the extremities because of gravity, and because of that, the patient won't have dyspnea. We'll limit activity because we need the patient to do as little activity as possible so that the load on the heart is reduced. Now we'll see which diagnostic tests we can do to detect heart failure. Now we will see what tests we can do to diagnose heart failure. So for the diagnosis of heart failure, a chest x-ray is done. In a chest x-ray, we can see cardiomegaly. We can see pulmonary edema. Besides that, an echo is done for the patient. an echocardiogram. In an echocardiogram, what we can see is that the ejection fraction is checked. Ejection fraction means the percentage of blood that comes into the heart's left ventricle, that is pumped out in one beat. Suppose this is our heart, this is its left side, and this is the right side. These are the upper atria, these are the lower ventricles. Now in this, for example, if there is 100 ml of blood, then in one beat, what percentage of this 100 ml will be pumped out? If, suppose, 60% is coming out, then eject means to pump out. Fraction means percentage. So ejection fraction, meaning how much percent of the blood coming into this ventricle is being pumped out, that's what we call ejection fraction. So the normal ejection fraction is from 55 to 75%. If this is 40, if this is below 40%, then it means the patient has heart failure. Okay? In a heart failure patient, the ejection fraction will be below 40%. Besides this, what other tests can we do for a heart failure patient? There's a BNP test, BNP. So this BNP, which was previously called brain natriuretic peptide, has now had its name changed. Now we refer to it as B-type natriuretic peptide. This updated terminology is important to remember, as you may still encounter both names being used in different contexts. BNP. That stands for B-type natriuretic peptide. B is for B-type, N is for natriuretic, and P is for peptide. So what actually happens is that in our heart, specifically in the ventricles of that heart, it's produced in their walls. The more the ventricle is stretched, the more BNP will be produced in it. So, as the stretch increases, it means in heart failure, when blood isn't pushed out, the blood stays right here, causing congestion. This means there will be pressure here, it will stretch. So, the more it stretches, the more BNP will be produced by the ventricular wall. And when we test for this BNP in the blood, it comes back elevated. So, the normal BNP level in the blood is less than 100 picograms per milliliter normally. And if it's higher than this, then we can say that the patient has heart failure. So a BNP test is also done for this. Why does this BNP increase? As its name suggests, it's natriuretic. Why does it increase? It's actually a good thing. What happens is that when the pressure inside increases, the heart feels that the pressure in the body has increased. So what it does is, why not remove sodium from the body? Because if it removes sodium, water will also be removed. And if water is removed, it means the blood volume will decrease. And if the volume decreases, the blood pressure will decrease. So that's why this hormone is produced here. In this process, as the name suggests, B-type natriuretic peptide, often abbreviated as BNP, is generated. This peptide, known as natriuretic, plays a significant role in the body. Diuretic. Diuretic means uresis. Uresis means an increase in urine. And natri is related to sodium. So it means more sodium is excreted in the urine. More sodium goes out through the urine, and since more sodium goes out, the urine will naturally follow it out. So, that was heart failure. See you in the next video with a new topic. Thank you.